evening, everyone. It is so good to see you. We are 90 and climbing. It is indeed my pleasure to welcome you from across the region, or could I say across the world, especially to our partners, our sponsors, and individuals who are not midwives. A very extra special welcome to any pregnant families that we have here, or even teens that are on this platform. Welcome. CRMA find it's an honor to join you in your homes or join you at work this evening. I see Magali, I see Merle, I see Nadia, Natasha Williams, Norma, Paula, Petra, and the list goes on, and we are at 105 climbing. So I thank you for accepting this invitation this evening. I am Cynthia Peter, your moderator for this webinar, and I'm coming to you live from Kingston, Jamaica. It is now 6:01 in Jamaica. My other team member for this evening are Mrs. Margaret Bourne Clark and Miss Marlo St. Hill, and they will be leading out in the question and answer section. It is indeed an honor to be working with you ladies this afternoon. We are a part of the Education Committee responsible for these informative, fantastic, and awesome webinars that you have been attending since 2020. CRMA is a non-governmental regional midwifery association. We are committed to educate, support, and strengthen professional midwifery association regionally. And such, we are conducting this series of webinars to build capacity among midwives, which will enable us as midwives to better care for the childbearing families. This evening, the spotlight is on adolescents. They are vulnerable. We are going to examine the sexual and reproductive health services available to them in the Caribbean and the laws that impact on their services and the rights of this awesome population. Our objectives for this evening are, we are going to review 2 selected adolescent programs, critically analyze the services offered by these 2 programs, examine the challenges and lessons learned from these programs, and finally, review laws that impact sexual and reproductive health services offered to adolescents, the Trinidad and Tobago experience. Before we hear from our presenters, we have our president, Dr. Shirley Curtis. She will be bringing greetings. She is not just our president, but our beloved president. I want to congratulate her and her team for this evening, for the webinars that we have been conducted. And we are creating waves across the region. And I'm very impressed with this leadership qualities, as midwives. So, Dr. Shirley, welcome.
Thank you very much, Cynthia. Thank you, midwives from around the Caribbean. My job here is a simple one. It's to welcome you to another one of our webinars. If this is the first time you are logging on to one of our many webinars that we have been having now since COVID. So when you think as long as COVID has been around, we have been doing monthly, almost monthly webinars. This year we started doing every other month, but we welcome you. We thank you for taking the time to come in to learn about things that impact sexual and reproductive health. And as we looked through the topics that we had presented before, we realized that this group of individuals had not been specifically addressed. And so tonight we are excited to hear from our presenters, our able presenters, and we are having them not just from one country, but we are having them from the Bahamas. Then we're going down to Barbados, and then we are also going to address the impact of the legal system on what it is that we do as midwives as we address adolescent health. So I just want to say thank you to Dominica, Nevis, St. Kitts, Trinidad and Tobago, Jamaica, Antigua, St. Lucia, Grand Bahama, and I've noticed that the islands of the Bahamas are spelling out their own island as if to say, don't just say Bahamas. So I see Grand Bahama, I see New Providence, I see Abaco, Grenada, Barbados, Belize, St. Kitts, British Virgin Islands, Turks and Caicos, Guyana. And if you have not heard your country, please put your country in the chat. And by the end of this presentation, we will recognize your presence here. Now, we know that persons, they also attend the webinars because they need their certificates for their CE hours. And there will be a Google form link that will be put in the chat probably by closer to the end. And in order for you to get your certificate, you must fill out the Google form, which will ask you for your name. It will ask you for your email address, as well as some other questions. And so once you have filled that out, it goes to our secretary, and she, after about 3 to 4, now we give you until, this is now the end of the month, so we give you until next weekend to fill it out. After next weekend, we assume that you are not interested in a certificate. So please fill it out now, and don't call us in 6 weeks to say, oh, I was there, but I forgot to fill out the form, right? So we welcome your presence, and we want you to get the most out of the presentation. And if that means getting a certificate, then you must fill out that Google form for us. We would also like to thank and welcome UNFPA for assisting us and sponsoring us in our webinar. They have been consistent from last year to this year in their partnership with CRMA, and we would like to thank and welcome their representative as well, who is a part of us, and we are proud of that, representing here today. But thank you, you're welcome, and please spread the word. For those who have not logged on as yet, we are up to 140 persons. And I know persons tend to register for these events and then forget because they're free. But we have registered over 400 persons. So remind your colleagues to come on in so that they can get the full length of the presentation. So thank you very much for coming, and welcome. Over to you, Cynthia.
Thank you, Madam President. That person that you spoke of, our UNFPA representative, is our beloved Deborah Lewis. Deborah Lewis is a registered nurse, a licensed midwife, and she has her MSc. She is now the UNFPA representative for midwifery. She's a consultant, and she's currently the co-chair of ICM's Scientific Program Planning Committee, and was selected by Women in Global Health as one of the 100 outstanding nurse and midwife global leaders in 2020. If you ask me, Deborah, you're best known for Mama Toto, I hope I pronounced that correctly, birthing center in Trinidad, a midwifery-led birthing center. I welcome you and over to you. Thank you.
Thank you very much, Cynthia, for the introduction. So on behalf of Dr. Vicky Camacho, who is the Regional Technical Advisor in Sexual and Reproductive Health, and also Dr. Pilar de la Corte Molina, who is the Sexual and Reproductive Health Advisor in the Sub-Regional Office in Jamaica. They send their apologies for not being able to be present tonight, but UNFPA is really pleased to be able to continue the support of midwives through CRMA. As Shirley mentioned, it's been a long history of partnership, but UNFPA is really pleased to continue it. And we're particularly excited about the webinar on adolescence, because one of our priority areas is adolescent sexual and reproductive health. So thank you to the presenters in advance. Thank you to all of the participants for joining, and really best wishes for this webinar series for the rest of the year. Thank you.
Thank you, Deborah. All right, so thank you, ladies. All right, so we have 4 presenters, as you heard, that will be doing the presentation this evening. Each presenter has 15 minutes. And we are going to take question and answers. Questions and we'll answer are your comments after all 4 presenters have presented. All right, so we are encouraging you to utilize the chat. And if you want to ask questions, then you indicate with the raise of hand button. We want to hear from you, so please submit your question, okay? Our first presenter for this evening, we are at 165 and climbing, is Miss Janelle Pickering. Janelle is a registered nurse from the Bahamas. She's pursuing her MSc in public health, and she has been working in the Adolescent Health Center for more than 2 years. She believes in service above self. She's a Kiwanis. She is the parent of a teen and a preteen. Her philosophy is the destiny of hard work is always success. I can do all things through Christ who strengthens me, and together we can accomplish much. Help me welcome Miss Janelle Pickering. Over to you, Janelle. Her presentation will be entitled Standalone Adolescent Services in the Bahamas.
Good evening, everyone. Can you hear me?
Yes, we can.
Okay, great. Let me just pull up my presentation. Okay, can you see the slides?
Yes, we can.
Okay. Good night, everyone. So my presentation tonight is on the standalone Adolescent Health Center in the Bahamas. So the facility, the approach to the Adolescent Health Center is holistic, comprehensive, as a multifaceted team management approach. So young people in the Bahamas face a myriad of challenges when it comes to their sustainable development. So contributing external factors include, STIs, drugs, substance abuse, and limited access to health services, poor nutrition, and environmental factors. So this is the current facility at Adolescent Health Center. It is located off of Shirley Street, which is right across from our main hospital, public hospital, the Princess Margaret Hospital. The center offers comprehensive health and social support services to the adolescent population between the ages of 10 years to 19 years. The clientele comprises of pregnant teens, mothers, their babies, male and female adolescents experiencing behavioral problems. And these clients are usually referred from either community clinics, from their schools, from social services, from the police, and from NGO facilities, or they are self-referred. Either they come in or their parents bring them in. So the goal of the program is to provide a holistic approach to healthcare for adolescents, regardless of gender, race, mental or religious status, and sexual orientation. This approach is aimed.
Sorry, Janelle, can you speak
Yes.
up a little bit? Some
Sure.
persons say they're not hearing you.
Okay.
Hello.
Yes.
Okay, great. So the approach is aimed at providing life skills needed to make the right decisions concerning their health and their well-being. The objectives of the program are to provide the holistic and confidential health care. You want to reduce the impact and negative destructive behavior that some of them may be experiencing. And you want to provide timely, age-appropriate, and culturally sensitive health education to these adolescents. And to be an advocate for their health issues, to make them feel that they are important in this world and their health issues matter. So the team members of the center include a coordinator, high-risk physicians that come from the Princess Margaret Hospital, and they are there to see the pregnant teens or any other teen there that has any high-risk issues. There is also physicians that are provided from the Department of Public Health, and they usually deal with other issues. We have pediatricians that also come to the clinic to deal with our infants as well. We have midwives, we have other nurses of all grades of staff. We have a psychosocial counselor, a nutritionist, a phlebotomist where we're able to take labs on site. We have a social worker who is attached to the adolescent center, not in-house, but we work with them through our social service department. Education officer who mainly through our PACE department with our kids, and then through Ministry of Education as well through our schools. The police department who helps us with our children. If we're having issues, we need to refer to them. Anybody, they're there to assist as well. And of course, we have our clerical support staff, securities, and then our NGOs as well help us with the program. So a little bit of history about adolescent health. It came about in the late 1980s. It was pioneered by Miss Kathleen Johnson. She realized that there was no special place for teens and teen mothers and no readily available, sources for them to be able to get care. So she then reached out to various partners through education, psychological services, nutrition, and the medical team to start the adolescent health program. So initially they were located on the premises of our public hospital. And then as the population grew, they moved to a space shortly right off of Shirley Street on Dowswell Street. And at that point, they were combined with the PACE school, which is a school for our pregnant teen girls. And as again, the population grew, they realized that they needed their own facility, and that's when they moved in this present location in the early 2000s. So the services that are offered, antenatal and postnatal care, psychosocial counseling, family planning and reproductive health services, nutrition management, laboratory services, drug screening, immunization for our older adolescents and the babies as well, health screening so they can come and get their school medical, their physicals yearly, they can come there as well. Education to make sure that they, mothers who are pregnant teens, they get the education to prepare them not only for labor and delivery, but for parenthood as well, and the fathers associated with these pregnant mothers. And then of course we do home visiting, so postnatal visits, we do, also we do just home assessments to make sure that these homes are well for these children or adolescents to return back home to. So we have a lot of partnerships, and this is just a few. So our PACE school, which is under the Ministry of Education, and it's providing access to continuing education. SASH Bahamas deals with our
LGBTQ population. So we want to make sure that all persons are represented and that there's no person that feels that they are left out. The HIV/AIDS Center, we have many NGOs that we deal with as well. Ministry of Education, Social Services, and of course our police force. So just a few successes. We have, like I said, a lot of successful partnerships. We have had trainings done with persons as far as, initiating condom negotiations. We have had where we've had urban renewal, which is a part of our police department going into the communities. We have also had partnerships with the HIV/AIDS Foundation to ensure that our kids get the education, the testing. If we have anyone that comes out HIV positive, they are seen at the clinic first, and then they are followed up through the HIV/AIDS Center so that they are not left behind. Bahamas Planned Parenthood also assists as well, providing additional means of contraceptives for the children, inner city groups for parents and adolescents. We have our on-site comprehensive team. And between 2018 and 2021, we had less than 1% return pregnancy rate, a decrease of 15% of our STIs. We have increased condom distribution, so we have them located throughout the clinic. And like I said, educational sessions prepare our adolescents for the workforce, because we know they're not going to stay young for forever. So we want to prepare them for real life. Our parent craft classes prepare our mothers, not only at the PACE Center, but we have girls that have been graduated from school. They are still under the age of 19. So we make sure that they are prepared as well for labor and delivery. And of course, we have our on-site laboratory where we can take our samples off. The samples are taken to our lab at the main hospital, results come back. We also can do drug testing on site as well. So some of our challenges, legislation, because unfortunately the children cannot access the center without their parents' consent. So we have legislation where you can consent to sexual activity at 16 years, but you are not allowed to access care without an adult until you're 18. So, there's a big discrepancy there. Presently, we have no on-site social worker. We work well through the Ministry of Social Services, but we would like an on-site social worker to be there. And of course, parental authority. So even if a teen feels that they want birth control, if the parents say no, then we always have that discrepancy there, or some other service. Like I said, they cannot access the service without their parents' consent. Consent form is signed once they are booked into the clinic. Once they are booked into the clinic, they're allowed to come without a parent if needed, because they've already given consent. Post-COVID, which changed the whole world, we had issues where there was fear of COVID, and that's for patients, their families, not wanting them to come to clinic based on what was happening in the country. So just giving them the education that was needed to ensure that they're able to come and seek the care that is needed. Of course, utilization of the space as the population grows, and then with COVID, the social distancing, that became an issue, but that has since been resolved. And then, of course, just the continuous education of the parents and their clients to let them know the facility is safe, the staff is safe, and we want them to be able to come and access the care here. So this facility is located on New Providence in the Bahamas, but we also have a second facility that is located in Grand Bahama. So the facility in Grand Bahama is PACE Grand Bahama. So unfortunately, they had some destruction that was done by Hurricane Dorian. This also consists of a multidisciplinary team, but all of their team, the entire team, is housed in one facility. So they have the actual school for the adolescents in the facility. They also have their physicians, they have social work, they have all of that under one facility. So right now, they're scheduled to reopen September 21. And from what I understand, they have a decreased number of clients now. So their program has been working despite the challenges of Dorian and now COVID. And this is what the facility looks like in Grand Bahama. So short and sweet presentation of our awesome program. We have to continue investing in health and well-being of our adolescents. And we have to make it a national priority for our policymakers to ensure that they get the care that they deserve. So I just want to acknowledge Nurse Patrice Hanno, Nurse Sonia Nesbitt, who assisted with the information for this presentation, the staff of Adolescent Health, and of course, the Ministry of Health, our Health Education and Research Unit. References. Thank you. Any questions, which we will get at the end.
Thank you. Thank you. I'm looking forward to the questions, that you'll get at the end and even the discussions. Yeah, so good to know that we have such facility in the Caribbean, in the region. So thank you for that. And I'm inviting you to stay so you can take the questions and comments after. All right. Thank you so much. Our next presenter is Mrs. Carrie-Ann Hurley, and it is my pleasure to introduce her. Wow, she's from Barbados. She is a social worker, having studied at the University of the West Indies, and she is a director of GEMS in the Rough, GITR, a youth empowerment NGO. She counsels and trained young people in the area of sexual and reproductive health and rights. She is a mental health and wellness consultant. She works across the spectrum, conducting individual therapy, small group support, facilitating tailor-made workshop on topics such as self-care. She's an etiquette consultant also, which she focuses on personal development and empowerment of youth. And finally, Carrie-Ann is a singer and a songwriter. She's best known for Sarah and has been blessed to have the release of her debut album, Butterfly, as her greatest musical accomplishment thus far. All right, so it's a 13-album track, and I'm sure she has it on YouTube thereabout. Go out and support her. She has gained attention globally from the Caribbean, America, Europe, Canada, and the list goes on, Netherlands. Ladies and gentlemen, help me welcome Mrs. Carrie-Ann Hurley. Thank you. Over to you, Carrie-Ann.
Thank you, Cynthia. Good evening, everyone. Can everyone hear me well?
Yes, we can.
Okay, wonderful. Thank you very much for this opportunity to be with you this evening to share from the beautiful island of Barbados about the wonderful work we've been doing with our adolescent population here. I'm gonna jump right in because I know I have limited time, but I am very passionate about working with young people, hence why a couple of years ago, we would have started this Young Mothers program. As you heard, I am the director of GEMS in the Rough, which is a holistic empowerment youth NGO here in Barbados. And I'm also the manager of the programming at the BFPA, also known as the Barbados Family Planning Association. And it is there that we've been running an adolescent and young mothers program, which I will tell you more about very briefly. But first, I wanted to start by, I don't have access to move my screen, so can we go to the next screen, please? The next slide. Yes, first I wanted to start by telling you about the SRHR services that we have for adolescents here on island, and they fall under a number of different categories. So we have education and advocacy, where we have our health and family life education and our comprehensive sexuality education programs and curriculums. Challenges immediately that we have with these are that one, the HFLE program is not comprehensively taught or given priority in schools. So we have a situation where HFLE is presented up to third form in secondary schools, and that's where it ends. And that is ridiculous, because that's the critical point in development for an adolescent when they're getting ready to turn 14, 15, 16, and they're about to enter into their adult, move into their adult life. That's when they really need the information and the support that is given within the health and family life education curriculum. So our response through BFPA and GEMS is that we support our Ministry of Education by facilitating sexual and reproductive health and rights sessions within our schools as requested. Similarly with RCSE, the biggest challenge we have is a misconception about the varying components of the curriculum, especially because that word sexuality is front and center. And many people get a little scared when they hear that we're coming in to talk to their youth about sexuality and sexual health. So for us, we have had to do a lot of advocacy and a lot of work, education, trying to get the public to understand really and truly what comprehensive sexuality education is, the benefits it has for our young people, and how we can go about presenting that information in age-appropriate ways. So we facilitate the CSC curriculum in part or in full within schools, throughout our communities, and even in our churches. We get lots of calls from many of our churches asking us to come in and to address a number of issues that they may have, or just provide information for the young people that they serve. Next slide. Under medical and clinical services, we provide services to adolescents, but as my colleague that just presented from the Bahamas mentioned, we too have a challenge where there's a discrepancy in the age of access versus the age of consent, and this is within the legal framework that exists here in Barbados. So the age of access to services is 18 years old, but the age of consent to engage in any type of sexual activity without your parents' permission is 16. So therein lies a critical issue. Our immediate response, particularly at the Barbados Family Planning Association, has been to establish and implement an access policy through a consultation with our local child advocate lawyer, who is also the UNICEF Children's Champion, Ms. Faith Marshall Harris. She assisted us in creating a policy that is steeped in the legal framework that allows us to be able to see and provide services to adolescents under the age of 16, or should I say under the age of 18, without parental consent, but it is done in a very systematic and a very thorough manner. It's not whimsical and by any stretch of the imagination. So there's a very clear structure as to how we are to engage with our adolescents within the framework of the law here in Barbados. Also, another challenge that we experience with our adolescent population accessing services is that there's an unwritten policy among our service providers where they don't want to see persons who are under the age of 18 without a parent or guardian. And this is not necessarily, this is directly, yes, related to the age of access versus the age of consent. But beyond that, it's just the practice that has been around for many, many years. So even though they can legally do it, it is the policy that has existed. And so we've been advocating at all levels for a change in this. And we seek to educate and train many of our medical personnel about our access policy so that they can better understand where they stand and how they can assist this population without getting into any legal issues. They probably still have to deal with the parents and parental authority, but for sure from a legal perspective, they would know that they have strong legs to stand on as long as they follow the policy that we were able to create. Next slide. Then we have the psychosocial support and the services that are provided to our adolescent population here. We have general social services, whether that's welfare. We have life skills seminars and workshops. And we also have counseling and mental health services. So challenges that we tend to experience here are barriers to access with this population, one being their age, two being their lack of financial stability or having the money they need to be able to access services that they may not be able to get free. There's also, I don't have it here, but actually it can come under culture and mindset. We do have services that are offered free within our polyclinics, but for some persons have a perception that those services may not be of a good quality, which is not true. We have very good quality services being offered through our government institutions, but some people just don't prefer to go there because maybe they're not comfortable or they're not seen or treated with the level of respect that they need to be treated with, even though they're adolescents. And so they may have to seek these services in the private sector, which come at a cost that they oftentimes cannot afford. Also, when it comes to mental health services, there's also the culture and the mindset, which is changing, but still exists in little pockets, that it is not cool, quote unquote, to access these services, you know, to have a therapist or to go to therapy. I say it's changing because for sure, COVID has shown us that persons are a lot more open to accessing counseling and therapeutic services because they realize they really need it. There are the challenges of coping with the pandemic and everything that has brought has driven persons to really reach out for these services. And also, I think as we are progressing, it is a little bit more cool now to actually have a therapist and going to therapy being a part of your everyday existence, especially within our younger generation, more so than our older one. So funding to facilitate the provision of these services is generally the biggest challenge we have to be able to provide these services at little to no cost to our beneficiaries. Our response, therefore, has been to seek out grant funding through the creation of projects specifically targeting this demographic. So for instance, our Young Mothers program, which I'll speak about in more detail in a moment. And we engage a lot of our psychosocial personnel, such as social workers and counseling psychologists, interns, and other volunteers to provide these services generally free of cost to help us be able to provide access to this population. Next slide, please. So now I'm going to tell you a bit about our Adolescent and Young Mothers program. And you can go on to the next slide. This program is one that we consider to be a flagship program here in Barbados, because we know that teenage motherhood or adolescent motherhood has largely been a problem for many, many years because of the majority of teen mothers not being able to access or have the basic parenting skills that they need, or they have limited support within their family systems and structures. We know that teen mothers are susceptible to the cycle of poverty, which creates great conditions for repeat pregnancies and high unemployment rates. And many do not re-enter formal educational channels, especially when they come from poor households and they have limited opportunities to learn technical and vocational skills. Next slide. So this program was created to address all of the things I just mentioned there. We work with unemployed young mothers between the ages of 10 to 24 years, and they must have little to no CSCs or no vocational skills. And that's really the basic requirement for being a participant in the program. Within the program, we primarily address key psychosocial and life skill challenges. So under psychosocial, it is the support of counseling and mentorship that we provide. For life skills, we provide them with seminars and workshops that help to build their life skills and build the knowledge that they need to apply these skills. We give them access to clinical and medical services to assist them in managing their sexual and reproductive health needs. And we provide opportunities through the accessing vocational skills so that they can gain employment or even have entrepreneurial opportunities to start their own businesses and have financial support. Next slide. So I'm going to just give a bit about the different components of the program. So firstly, with our psychosocial and clinical support, each participant is assigned to a counselor who provides psychosocial support and mentorship throughout the life of the program. I should mention that we usually run a cohort of about 25 to 50 girls, depending on the funding that we have at the time for the program. But each participant has direct access to a counselor who provides them with the support and mentorship they need throughout the entire life of the program, as well as their family members and their partners. Participants are required to participate in weekly individual and group counseling sessions, and they are allowed to access all the clinical services necessary that we provide at the BFPA. Next slide. Under our life skills component, we conduct weekly empowerment and knowledge building, skill enhancing seminars and workshops on a wide range of varying topics that are key to their development and that are vital for them just to navigate life. Next slide. So these are some of the modules that we have within our life skills. Under personal development, we address things such as empowerment and life coaching. We do etiquette and social graces. There's self-care, there's body image. You can see the list there. And this is just a few. I was not able to list all of the things that we cover. These are just a few of the ones that we cover under our personal development module. Next slide. Under health and wellness, we address their sexual and reproductive health and rights. We look at postpartum depression, mental health. We even do nutrition and growing your own food, which is critical, especially as COVID came in. Many of the girls reached out to me and said how grateful they were that they were able to learn how to grow their own food, because COVID caused them to have to tap into that skill to be able to keep food on their tables for themselves and their families. And we help them to learn how to budget as well. Next slide. Parenting 101, a range of topics we cover here, from parenting and co-parenting all the way down to time management. We address things like better birthing and breastfeeding, which is critical for our pregnant mothers who are in the program, who may go on to have their babies while they're in the program or even after, as well as those who are breastfeeding. And then we deal with things like difficult situations, you know, discipline versus punishment, etc. Next slide. Budgeting and finance, we help them to create financial plans for themselves. We help them with goal setting when it comes to their financing, how to create realistic budgets, and even how to start to teach their children about budgeting and how to manage money. Next slide. We prepare them for the world of work. So we assist them with preparing things like curriculum vitae and writing application letters, and also doing upskilling themselves with their interviewing techniques and skills. And we also address things like suitable grooming, how they should present themselves when they're going for interviews. It's a really exciting part of the program because they actually have to do role plays and mock interviews, and they have to dress and come as if they were actually attending a real interview. And then under our component for vocational skills, each participant is given the opportunity to enroll in a course of their choice and interest. Our key partner is the Barbados Vocational Training Board, but we also have other organizations that we work with who also take the girls and help to give them the skills and knowledge they need to have these tools that they can use then to advance themselves. Next slide. So these are some of the courses that the girls generally would apply and join, and many of them go on and start their own businesses in cake making, decorating, braiding and weaving. And we oftentimes tend to then go back and draw on their skills when we need stuff done. So if we need pastries and cakes done for an event, we turn to the girls and we help, you know, we invest back into them to help them kind of build their skills further. And out of this, we also bring back many of the girls to assist within the program and also teach some of the skills that they have learned to new cohorts who are coming into the program. Next slide. So we have lots of fun within our program as well. We make sure that we celebrate the girls, especially when we have pregnant young mothers who are in the program. We have baby showers and we go and we support them as they are, you know, giving birth to their babies in the hospital. And we just, it's one big family that is created out of the experiences shared. Next slide. We also make sure that they get some downtime. So we have picnics and we play fun games and stuff, because many of these girls don't get a chance to just relax and breathe. So we make sure that we have family days as well, where they can just let the children play and have fun, and they themselves can just relax and have fun. Because remember, these are young mothers. Many of them are teens and adolescents. They themselves are very much still very childlike, and they themselves are still trying to balance the responsibilities of being a parent, as well as still just trying to, you know, be true to their youthfulness. Next slide. We end each cycle of the program with a graduation ceremony, which celebrates and highlights the journey of the participants, which many times is very emotional to just sit and walk through from day one to the very end of their journey within the program, and to see the growth and to see the development, and to hear the girls themselves speak about how the program has impacted their lives and has really made them better mothers, better women, just better people in general, and to see the trajectory of where they're going. Next slide. So COVID has impacted us in many ways. In particular for the Young Mothers program, we would have had to put the program in its normal way on hold because we couldn't have the face-to-face interaction that we would normally have, especially because this type of program requires that face-to-face engagement. The impact is not the same virtually. Simply coming together and being in a room, sitting together, talking, sharing, you know, being able to touch and to just be there to support each other means so much to these young women. So we did transition virtually to have many of our sessions online, our support group sessions, etc. But oftentimes, some of the negative challenges that we had were things like or limited remote access or connectivity. So some of the girls were unable to connect, or they couldn't connect completely because of poor internet service or not having the relevant devices they needed to get on, as well as not having a conducive home environment to really sit down and just have a session. And that was also the same for the work that we do with our wider adolescent population, where many of them were unable then to access our services at our clinic at the FPA. And even though we were able to continue some of our psychosocial services to them, similarly, they had challenges with connectivity and also not having maybe a conducive environment at home to be able to facilitate these sessions. And then the financial strain that we all felt, especially as we have reduced revenue because our clinic would have been closed for a while, and then the reduced capacity of persons that we could see, yet still having to deal with the increased client needs that started to come forth. So we've been working hard. We found ways to pivot and to just rise to the challenge, but it has been difficult in many ways. However, we've still been able to service this very critical and important population. We couldn't leave them alone. And I'm grateful that we are starting to see a change in the tide, and we are getting back to a place where we can, build back up our support to this population here in Barbados. So that's it in a nutshell. There's so much more I can share, but I really try to condense it for the purpose of my time this evening.
Thank you so much, Carrie-Ann. And I'm sure my colleagues would agree with me that we could just sit and listen to you endlessly. You know, you were getting so many positive comments in the chat. Susan, Eureka, Abigail, and so many other persons giving you so many positive comments. And it is a flagship ship, and we, you know, other countries, if we don't have something like that, we could model this. All right, thank you so much. All right, so we are 245 per participant and we are climbing. Our final presentation, so we have heard from Barbados, we have heard from the Bahamas, and now we are going to hear from Trinidad and Tobago. This presentation is entitled The Role of the Children's Authority of Trinidad and Tobago in Child Protection. We have two presenters who will be doing this presentation. And it's my pleasure to introduce to you Miss Damali Nichols. She's a practicing attorney at law, having graduated from the University of the West Indies and the University of Warwick, where she did postgrad studies also in international development law and human rights. She currently works at the Children's Authority of Trinidad and Tobago, and my dogs are popping up. She has been involved in the promotion and development of child protection in Trinidad and Tobago for many years, and she is presently the convener of the Counter Trafficking Subcommittee on Human Rights Committee of the Law Association of Trinidad and Tobago. I will use this opportunity at the same time to introduce Miss Elena Bouchan, I will pronounce that correctly, who is currently the acting assessment manager at the Children's Authority of Trinidad and Tobago. She's a registered psychiatric social worker. She is also a graduate of having completed a bachelor's and a master's degree in social work. She's a board member for the Help and Restoration for Families. Her passion is working with children and families. Ladies and gentlemen, help me welcome Elena and Damali. Welcome, ladies.
Thank you very much. So good evening, everyone. So my name is Elena, as was introduced, and Damali and I are here to speak to you a little bit about the Children's Authority, who we are, our role, and as it relates to child protection. So the Children's Authority of Trinidad and Tobago is the statutory body that was set up with the overall responsibility for child protection in Trinidad and Tobago. Next slide, please. So today, we're going to give you a little bit of background, vision and mission, mandate of the authority, situational analysis, services offered, elements of the child protection system, and we're going to deal with medical consent. It does seem like a lot, but I will be brief with many of these things, so don't worry. We'll take you through as quickly as we can. Excuse me. All right, so Trinidad and Tobago is signatory to the Convention of the Rights of a Child, and in keeping with that, we have created a package of children's legislation, which was developed in 2000 with the Children's Authority and child protection at its very center. These pieces of legislation were proclaimed in 2015, and that's when it is the authority finally had the legal authority to deliver on its mandate, which is actually quite wide. Next slide, please. Okay, so child protection, like I said, is at the center. So our vision is to defend and support child rights and to make child protection everybody's business. So, and our mission is to promote the best interests of children through advocacy, prevention, intervention, and collaborative strategies based on multidisciplinary approaches. The Children's Authority, of course, cannot do this alone. So we do partner with a number of other state non-governmental agencies in order to fulfill our mandate, vision, and mission. Next slide, please. All right. So as I had mentioned before, we have a very wide mandate. Could you just click so we could bring up all of the various functions? All right, so first off, it's receiving reports of child abuse and neglect. We are mandated to investigate these reports. We may conduct further assessments on the children to determine appropriate placement and interventions. We manage the foster care and adoption system. We are also responsible for the licensing and monitoring of the community residences or children's homes. And we also provide support to the youth justice system. So this is children in need of supervision, as well as children who are in conflict with the law. All right, so the Children's Authority is a fairly new organization, having only been set up in 2015. In these last 6 years, however, the caseload has been quite large, and the authority has received on average between 4,000 to 5,000 new cases each year. So the caseload definitely is way more than the resources that we have received, and it's well beyond the capacity that was expected, but we are trying our very best. We have, over the last few years, we've seen an increase in the number of children who present with mental health challenges, as well as behavioral challenges. And of course, sometimes with mental health challenges, you do get the behavioral presentations. Next slide, please. So this is just a snapshot of some of the trends and some of the data that we've collected over the years. As you will see from our caseload graph, the numbers have been from 3,348 new reports in May to December of 2015. It increased to 5,322 in 2016. And the numbers have stayed between that 4,000 and 5,000 mark over the last few years. And these are new cases. So it's not that we are getting, we're not counting all of the additional reports that may be coming in on more than one interval. So these are all new cases that are coming in each year. The three most common forms of child protection concerns, that we have been seeing are neglect, sexual abuse, and physical abuse in that order. It's important to note that in many instances, it's not a single form of child abuse that you see. Oftentimes, you may have more than one type of abuse happening to a child in this scenario. In terms of geographical distribution, we have it listed out according to our regional corporations. As you will see, the areas that are marked in red are those with the highest concentration of cases. That East-West corridor, which is also a very densely populated area of Trinidad and Tobago, also has the highest number of cases being reported. In terms of the sex of our clients, it is more females than males, but you'd realize it's not a very large difference between the two, 55.8% female and 42.2% males, with 2.1% being unknown. As we do sometimes get reports of children, but the reporter can't tell you whether it's a boy or a girl, and we'll only get that information after we've gone in to investigate. And with regard to the age of the clients, the 10 to 13 age group tends to be the largest number that we get. So I spoke about some of these trends that have been noted. It's important to know perpetrators are oftentimes known to children, and harsh punishment and humiliation are still very prevalent and are part of our day-to-day experiences and very much ingrained in the culture to some extent. Next slide, please. All right, so just going to go through very briefly some of the services that are provided by the Children's Authority. And in keeping with our functions and our mandate, the investigation of reports, the assessment, as was mentioned, I am the acting assessment manager. At the assessment center, we do multidisciplinary assessments. So the team consists of social workers, psychologists, and medical doctors. We do forensic medicals as well, and this is for children who have been the victims of abuse. So we would do the medicals for the purposes of gathering evidence, whether it's a case of physical abuse or sexual abuse. We are not the only entity that does this. The Ministry of Health and the various district medical officers also do the same, but we do provide some degree of support. Our emergency response team is there for children who are in imminent danger. They are on duty 24/7. So it's not a matter of you can't get through to a government agency because it's beyond 8 to 4 Monday to Friday hours. Our foster care temporary placement for children who are in need of the same. Adoption is a more permanent, is for more permanent placement, obviously. Licensing and monitoring of the community residences. As I mentioned, we do have responsibility for ensuring all of the children's homes are licensed and they are meeting specific criteria in order to get that license. And we do monitor the care that's afforded to the children. So it looks at not just the infrastructure of the homes and how things are set up, but also look at the care that is afforded to the children there. The temporary placement, CSC, it stands for Child Support Center, which is essentially our own facility that we have set up in instances where we require immediate placement and we are unable to secure a space in either community residence or foster care immediately. So it's usually, it's for short term, very temporary placement, usually not exceeding a period of 12 weeks. There are instances we do go over, but we try as best as possible to keep the placements at our child support center very brief. And in that time, do what we need to in terms of doing the necessary assessments and linking the child and the family to the necessary resources. The filing for legal applications, once a child is received into the care of the authority, we do have to make an application, get the orders, the care order, or whether it is we put them with a family member or family friend, to get the necessary legal orders for coverage to ensure their safety. In terms of psychosocial intervention, the aim is always to work towards the rehabilitation of the child. So we do a number of different types of interventions, both with the child and the family. Next slide, please. We could go through some of those type of interventions that are provided. So we do a number of referrals. We link we do that brokering service of linking the families to other agencies that have responsibility for the same. So whether it's referrals to our social welfare department, to National Family Services, to our Student Support Services Division, all of these other agencies that have been set up to provide the necessary interventions, we try to broker the services and network with these agencies to get the children and the families the support that they need. In terms of monitoring visits, while the child is being is in the care of the authority or the has oversight, or the authority has oversight over them, we may follow up consistently through school, at home, community residence, wherever it is that child might be. We may link a parent to parenting training, crisis intervention, whatever the necessary psychoeducation sessions, therapeutic intervention, as a case may be required. Each one is looked at individually. It's not a one size fit all. So we do look at each case and we link the family as required. Next slide. Okay, so in terms of referral pathways and accessing the services of the Children's Authority, given the ongoing COVID-19 pandemic, we have not been recommending persons walk in to make referrals anymore, but we've always had the avenue of a hotline. Number is 996 or 800-2014. It's operational 24/7, and you can make an anonymous report. So anyone can make a report through the hotline. We also have an email address set up where emails can be sent with your reports. So these are the two main ways by which we have been receiving reports for the time being. Before that, walk-in services were also afforded. While if a person does come in, we will try and we'd get the information anyway. We have been, in the midst of this pandemic, we have been recommending that people utilize the hotline and the email address more so. Next slide. All right, so I'm going to hand you over now to Ms. Nichols, who will take you through the legislative context. And I just want to reiterate that we're going to be speaking more so about the child protection legislation and not specifically the legislation as it with regard to access to healthcare. Okay.
Hi, good night, everyone. So as Elena would have indicated, the children's package of legislation was based on our commitments under the United Nations Convention on the Rights of the Child. So Trinidad and Tobago did ratify that in 1991. And what I'm going to go through is the definition of a child, cruelty, persons who are considered to be in a position of trust, sexual offenses against children, mandatory reporting, the Romeo clauses, and consent to medical treatment. Now, this is focused in Trinidad and Tobago, but what I would like you to pay particular attention to is where the law here requires medical practitioners, which would include midwives, to report certain things to either the authority or the police. Next slide, please. Now, the Children's Act of 2012 was revolutionary in that it established that children were rights holders, which is based on the United Nations Convention. Now, you can imagine if you have an act in place that was established in 1925, the thinking around then would have been that children should have been seen and not heard. And a lot of, outdated things like that. So first of all, children and a child is anyone under the age of 18. Next slide, please. So the Children's Authority deals primarily with children who are found to be in need of care and protection. When reports come into the authority, that really activates the authority into our investigative framework. So a child who is in need of care and protection is a child under the law who has neither parent nor guardian who is fit to exercise care and guardianship. A child who may be lost or abandoned by their parent or their guardian, and their parent or their guardian may be prevented by some medical, infirmity or incapacity from taking care of that child. Next slide, please. It is also a child who may be exposed to moral danger, a child who is in need of supervision, a child who is ill-treated or neglected in a manner likely to cause that child suffering or injury to their health, a child who is destitute or found wandering, found begging, a child who frequents the company of any criminal. Next slide, please. So children who are in need of supervision are actually children who come before the court where their parents indicate that these children are beyond their control. So parents would make an application to the court and then they're treated as such. Now, the reason I would want you to pay attention to a child who's needing care protection and some of those categories is because you would be required to make reports to the Children's Authority if you suspect that any of the children who come to your attention may be children who are in need of care and protection. So the law says that a police officer or any other person having reasonable grounds for believing that a child is in need of care and protection, they may seek the assistance of the authority for care and protection of that child. So that is why we encourage persons to pay attention to our hotline number. You make that report to us. That report is received by our registry unit, and then the Children's Authority can activate that. So under the Children's Act, the Children's Act deals with cruelty to children. So Section 4 says that a person who willfully assaults, ill-treats, causes, or procures a child to be assaulted, ill-treated, neglected, or abandoned, or exposed in a manner likely to cause that child suffering or injury to his physical, mental, or emotional health, or where there's an infant under the age of 3 years and that infant dies whilst in bed or any other place with that person, and it is proved that the death was not caused by disease or any other medical cause, the person at that material time, if they were under the influence of alcohol or dangerous drugs or a substance similar, and it results into the death of that child, they have committed the offense of cruelty to a child. Next slide. Move on to the next slide, just in the interest of time. And that next slide. So what I would want persons to also pay attention to when you are looking at clients who may come before you and they may have evidence of physical, emotional abuse and neglect, and in considering the information that they provide to you and whether you make reports to the police or to the Children's Authority or both. Remember that nothing prevents parents, teachers, or other persons from having lawful control, who have the lawful control or charge of a child, to administer reasonable punishment to that child. However, reasonable punishment does not include corporal punishment, and only parents or guardians can use corporal punishment in relation to children. So when children bring information before you and you receive that information, for example, if they say that their teacher may have inflicted corporal punishment, that is something that you should report, and you can also inform the child of their rights and particularly of the law as it relates to Trinidad and Tobago. Next slide. So persons who are in a position of trust, next slide, are persons who can be a constable, a medical practitioner, a nurse, a social worker, a teacher, scoutmaster, etc. These are persons who are considered to have either custody, charge, or control of a child, or persons who are likely to have unfettered and unsupervised access to children. And in the case of midwives, you would fall under that category. Next slide. So persons who are in a position of trust and medical practitioners, by the nature of that special relationship that you have with your patients, when persons are in a position of trust commit any offenses under this act, the Children's Act, and sexual offenses, the penalties tend to be more severe because you are a person in a position of trust than someone who would not regularly have that kind of access to a child. And as you can see, the penalties are laid out there. Next slide. So I want to just go through some of the sexual offenses against children under the Children's Act. So sexual penetration of a child is the insertion of any body part or object into a child's bodily orifice, or the insertion of a part of a child's body into a person's bodily orifice. We also have sexual touching of a child. Next slide. So the definition of sexual penetration, sexual touching, and any other sexual activity. So when it becomes that of a sexual nature versus something that is medical, is if it's done for medically recognized purpose, if a reasonable person can consider that the person's purpose in relation to it, because of its nature is sexual, or because of its nature it may be sexual, and because of its circumstances or the purpose, any person in relation to it or both, it is sexual. So the Children's Act created several offenses that were, some of them were quite groundbreaking, including child pornography. And I'd also like to focus on something that we may not be very familiar with in our region, but the Children's Act also outlaws female genital mutilation. And I don't know how many of you all may have encountered that. It may be a rarity, but the legislation took the ground that if it were to come to our shores, we have it in place that it is outlawed in Trinidad and Tobago. Next slide. So under the Sexual Offences Act, all of these sexual offenses that would have been relayed to you previously, certain categories of persons are mandatorily required to report sexual offenses against children. So those persons would be the parents or guardians, persons who have actual custody, charge, or control of children, or persons who have the temporary custody, charge, or control of children. Next slide. Who would include, of course, their teachers, etc. And someone who is a medical practitioner, a registered nurse, a midwife, or has performed a medical examination in respect of a child. So under this legislation, midwives and all medical practitioners, you are mandatorily required to report sexual offenses against children. So some years ago, Trinidad and Tobago actually had an issue where we had a former Minister of Health indicate that doctors were not required to report, instances of sexual abuse or sexual activity regarding children because of their client doctor privilege. And the Ministry of Gender, Youth and Child Development at the time would have had to issue a statement regarding that, because as you can clearly see, all medical practitioners must report sexual offenses regarding children. Now, the law had to be amended to include other categories of persons. And even if you yourself may not be aware or you did not receive the report, if you know that there are psychiatrists you work with, psychologists, police officers, social workers, they also have to they are mandatorily required to report these sexual offenses to the police as soon as reasonably practicable. Next slide. If this is not done, the penalties can be severe. You can be fined up to $15,000, or you can serve a term of imprisonment for 7 years. Next slide, please. Okay, so I just want to quickly run through the Romeo clauses in Trinidad and Tobago. So the concept behind this was that sexual activity between adolescents who are considered close in age should not find those children then criminally liable. So the law put different categories whereby a child who is 16 years or over but under 21 years is not liable for their sexual activity with a child if that child is 3 years older than the child against whom the offense has allegedly been perpetrated. Now, we can move on to the next slide. Similarly, if a child is 14 years or over, but under 16 years, they are not liable for sexual penetration or sexual touching of a child if that child is less than 2 years older than the child against whom the offense has allegedly been perpetrated, is not in a familiar relationship or in a position of trust, is not of the same sex as the child, and the circumstances do not reveal exploitation, coercion, threat, deception, grooming, or manipulation in the relationship. So I want to actually focus on those particular categories. So if you know that you have children who come under your purview, obviously, you need to, please go back to the other side. You need to pay attention to the circumstances that these children reveal their sexual activity took place. Even if it is a person who may be 18 and that child is 16, if you're hearing circumstances where the child indicates that they may actually have been involved in human trafficking, they were threatened, that they were forced into this sexual activity, that has to be reported. That is in fact a crime, and the defense of close in age would not stand. Next slide. Next slide. Now, the Sexual Offences Act also created, the amendments to the Sexual Offences Act, I should say, created some new offenses to deal with the different ways that children could be exposed to grooming and sexual communication. Now, originally under the Children's Act, it only provided, that is the Act of 2012, it only provided for sexual grooming. And the issue that we faced was the offense of sexual grooming had to occur on at least 2 occasions for the offense to be constituted. And when amendments came through the Sexual Offences Act in 2019, it was realized that we were losing perpetrators, in other words, based on that requirement. So as you can see with the offense of luring, the communication actually only has to happen 1 time for the offense to be committed. So under this offense, anyone who coerces or tricks a child or attempts to coerce or trick a child or person whom they reasonably believe to be a child into communicating with that person by any means, including electronic means, for the purpose of meeting the child or the person whom they reasonably believe to be a child with the intention of engaging in sexual activity or doing anything in respect of that child or the person whom they reasonably believe to be a child during or after the meeting in Trinidad and Tobago or elsewhere, and which, if done in Trinidad and Tobago, would constitute an offense under the Children's Act and the Sexual Offences Act, that person commits an offense. Now, these particularly categories that I'm going to go through, luring, sexual communication, and sexual grooming, have been particularly necessary and instrumental due to the age that we live in, to deal with the WhatsApp, the TikToks, the Facebook, all of that. Next slide. Can move on to the next slide. So sexual communication was also a new category that was created. Now, in this particular offense, where someone coerces or tricks a child, or attempts to coerce or trick a child or person whom they reasonably believe to be a child by any means, including electronic means, and the communication is sexual and it is intended for the purpose of attaining sexual gratification or encouraging the child to make communication which is sexual, that person commits an offense. Next slide. Sexual grooming. Now, again, I did mention that this is where on at least 2 early occasions, someone met or communicated with a child or communicated with a person whom they reasonably believe to be a child in Trinidad and Tobago or elsewhere by any means, including electronic means, for the purpose of sexual grooming, where they make arrangements to travel with the child or meet the child, where they have any intentions of doing anything in respect of that child. And it constitutes an offense under the Children's Act and the Sexual Offences Act. That person has committed an offense. Next slide. Now, this deals with the liability for all of them, but what I also want to point out is where you believe a person may reasonably be a child. And that is because our law also allows for police officers who are working undercover, pretending to be a child, that they would not be charged or they would not face any penalties as such. And of course, that we can still charge persons who may communicate with someone whom they reasonably believe to be a child. Next slide. Now, there are no laws in Trinidad and Tobago that make provision for children to consent to their own medical treatment. And usually parents or guardians give consent. However, we have to turn to case law, particularly the case of Gillick and West Norfolk. Now, in that case, that dealt with children under the age of 16 and whether they could consent to either being prescribed contraceptives or to receiving information regarding contraceptives. And what the court held in that case was that children, it should not really be based on the age of a child and to put that limit in terms of 16 and over 16 and under, but really focus on the age, maturity, and intelligence of a child. Can we just go back up, please? Right, to focus on the age, maturity, and intelligence of a child when making those decisions and their ability to consent to medical treatment or medical advice. Further, there is also another case, HIV/AIDS testing. It dealt with the HIV/AIDS testing of a minor, where parents were withholding their consent to that and to the consent actually of the child receiving the treatment required for HIV. And the court in that case would have indicated that that is an emergency medical procedure and that was needed, and that a child could consent, but also that the parents' consent could be dispensed with. Because the main focus when it comes to children of all ages, once a child who is 17 and under, is the best interest principle. And where parents are unreasonably withholding their consent for medical treatment, the court would look into that and can possibly dispense with their right to consent. So that brings us to the end of our presentation, and I thank you.
Right. I thank you too. That was impressive, and congratulations on the work that are being done in Trinidad and Tobago. I'm sure we are going to generate a robust discussion now with our questions and answer. So let me hand over to my colleagues, Margaret and Marlo.
Hi, good night again, everyone. And tonight, our presentation so far, Marlo, you're there?
Good night, everyone. Thank you for the beautiful presentation. Quite enlightening from all the regions so far.
Yes, there were. Yes, there were. Ms. Pickering, I would say that you're standalone. Although you're saying it's a standalone adolescent healthcare center in Bahamas, it is giving it structure. I like the structure, and it is giving good care, and it has a good foundation. Yes, I do support, and I do see that you have that need for that social worker to be on hand there, that anytime these persons are there and their case presents for a social work consultation, it should be able to be had there and not just as you need, you call in the person. Yes. Now, so far from the chat tonight, there haven't been many questions, I would say. I'm looking at the chat and I haven't seen questions. However, what I have seen from the session is lots of comments. Miss Carrie Ann. Oh, a lovely presentation, Carrie Ann. Lovely presentation. You have been given good accolades. Nice. Just reading a few. Nice. Very supportive and very supportive and developmental program for pregnant adolescents. One person said, "Great job, Barbados." Wonderful program. Excellent work, Carrie Ann. Well organized, great program, comprehensive program, and there was also admiration for the program. So to this, I say, Carrie Ann, take a bow. Nothing comes easy, and I know and I do anticipate that it was a lot of hard work.
Yes, it has been. It's a labor of love. That's what it is, a labor of love.
Oh yes, oh yes. Oh yes, oh yes, I can see. And because of that, I'm also seeing there's a lady here, I'm not sure where she's from. Her name is Naomi Thomas. Naomi Thomas.
Kimberly Alfred?
No,
I thought you were mentioning Kimberly Alfred's presentation. She said she's envious of our program. Kimberly,
oh yes,
no need to be envious. Kimberly. We are in a collaborative society where we are willing to share and make sure that we all come on board. Yes. So that program that's on board for Barbados, you're most certainly to adopt the model and run with it, because we are looking after our adolescents across the region.
Across the region, yes.
So we are here to share and care for each other, certainly.
Well, also on that note, Naomi Thomas, she also made a comment tonight that it was a very good presentation, and it's timely since her ministry is now trying to develop an adolescent program. I'm trying to, I don't know which country you're from, Naomi, but we are in a network, and as a network we can share that you can also grow. So I do, Carrie Ann, please correct me if I'm wrong, but I know that you'll be willing to help with guiding and sharing how to grow and how to develop such a program in your territory. Remember, yes, we have a motto in this Caribbean, and I can say we can extend it to the world, that we are one people. We're just little, sometimes just water separates our lands, and so, but we have similar needs and similar goals. One thing I would say, Marlo, any further comments on that area?
Well, for Carrie Ann's presentation, good night again, Miss Hurley. I wanted you to go a little bit more in detail about, you mentioned in your presentation about provision of services for those adolescents 16 and under, and that special type of program you had in place for them. And those ones who were really met with parental challenges and the opposition from the parents to really step in and operate in the child's best interest. I would have liked to hear a little bit more about that from your presentation. I wanted a little bit more detail in terms of how you all went about providing those services for those under 16.
Right. So as I mentioned, we have our access policy, and this is specifically at the Barbados Family Planning Association. And our policy would have a structure built in where any person under the age of 18 who seeks to access services and may be presenting without a parent or guardian, we don't ever turn them away, first and foremost. We don't turn away any adolescent, young person, or young person who comes who indicates that they need help. And I'm of the firm belief that for a teenager, an adolescent, a young person to either physically come to a clinic or to call and say, I need assistance, they must be in dire straits. They must really need that help. So we don't turn them away. That's where we engage the support of our social workers to work with this person to do a needs assessment and find out what's happening. So before they even are seen by our medical staff, they are seen by our psychosocial team so that we can try to figure out what's going on, what brought you here. Once we have established what's happening and why they would have come to us for help, then we collaboratively work with our nurses and our doctors to figure out what is the best course of action to take in providing the relevant services that this young person requires. Oftentimes, they may require some kind of medical support, but sometimes it doesn't always get that far. Sometimes it actually stops at the psychosocial area, and we may have to refer them out to another organization, or we may have to bring in another organization to collaborate with us further, depending on what the needs are of that young person. Ultimately, though, within the model, because of the way the framework of how the law has caused us to shape our policy, it is ultimately the doctor's decision to provide the medical care and attention that young person needs. And that's because the doctor has the final say in whether they need the provision of that service. And I was happy to hear my colleagues from Trinidad talk about the Gillette principle, because that is one of the cases that Faith Marshall Harris would have assisted us in structuring our work around to ensure that it fell squarely within the legal framework, and that we didn't find ourselves in any challenges or hot water. If we needed to go ahead and provide a service to a young person, even if they did not have the consent of their parents. Yes. So the social workers and the psychosocial teams are the ones now that would be the mediators to work with the parents, the guardians, whoever, to try to help them to understand why it is critical for this young person to access this service. And even if they don't come around to it, like I said, if the doctor deems that this teenager, this adolescent needs to have whatever that medical service is, under the law, it can be given, and the doctor would have the legal backing, so to speak. It is not an easy decision because you still have to deal with the
parents.
The parents.
And they have to contribute to the sustenance of the child after the child has left medical care.
Absolutely. So that's another dimension that we have to bear in mind, that after the child has left medical care, we still have to consider what the fallout could be And how do we support them and continue to ensure that they are taken care of beyond?
Also to, thank you for the explanation, Ms. Hurley. Also to Deborah Lewis, she has made specific mention in her question. She's asked, all of our countries have mentioned the difference between the age of access and the age of consent. How are we realistically managing that though? Because I mean, from 16, you're saying it's quite all right to give consent for one thing. And then by 18, you're saying, no, you have to bring a parent. And what traction have we made so far in terms of closing this gap? Because this is going to be a sore thumb. And until we get it right, we're either going to lower the age, it's going to take some legal work, but are we going to lower the age, or are we going to up the age for when they can truly and legally give consent? Because I mean, that's such a gray area, and it's always going to pose problems, and we're not going to get away from it by just dealing with it on a case-by-case basis. It has to be addressed. And I think that as a regional body, you know, we can make a stance in the Caribbean, because somebody has to bell the cat. Somebody has to say enough is enough. Where are we going with this as a body of regional midwives? And this is the particular area, and we know we meet a lot of bumps along the way, especially with the young girls who become impregnated, for instance, and they say, well, I can't carry through with this pregnancy. And then, you know, they may or may not want to continue with it, having done all the counseling and so on. They say, well, I simply can't continue with it. How are we going to address that? You say, well, you have to bring a parent. I mean, you've just explained the doctor will have the ultimate decision, but do we need to constantly torture our teenagers at that level to really put them through all of the other persons and all of the other layers that they need not have to go through, as opposed to really getting to the crux of the matter and really dealing with it where it makes sense for all?
So Marlo, so to whom are you addressing your question?
This is
I think our counterparts from Trinidad could answer.
Yes, this would be nicely put towards
our legal team.
Yes,
Damali, and the traction that she has made in terms of the legal framework that has been put in place.
You're muted.
Hi. Okay. So regarding that, so just to note, the legislation that Trinidad and Tobago has in place really pertains to child protection. Now, we don't have legislation in place regarding consent and that legal age, as was indicated in the presentation. However, we are guided by GILIC principles. I am aware that our regional health authorities also are guided by the GILIC principles, but I would not want to speak out of turn in terms of how they implement the policy itself. Now, where children have concerns in terms of their medical health, where there's an emergency and parents are unreasonably withholding their consent, the guidelines that have been provided by case law are apt, because you have to focus on the best interest of a child. And if parents are unreasonably withholding that consent where it threatens the child's life, the courts would not allow that. And so therefore doctors can stand on that. Even regarding contraception, the case outlines that you can't just limit it to the age of 16. You focus on the age, intelligence, maturity, and certain other criteria regarding children, their maturity in dealing with whether their access to contraceptives or that information. Now, as a rule of thumb, I would of course suggest that you obviously consent with parents. They haven't lost their parental rights. But where you're looking at the fact that they may be unreasonably withholding those rights, and you're looking at the best interest of the child, then you might start to want to apply the test that was laid out in GILIC against West Norfolk. And I really do encourage all participants to have a look of that case. I would also encourage you to look at a case called REC, a child HIV testing, because that case really dealt with what is considered medical emergencies and parents unreasonably withholding their consent, where the court would just override their parental rights and their consent.
Ms. Nichols, can you type them in the chat for us, please?
Yes, please.
Sure, I'll do that.
Can I also
now,
add?
Another question, yes, go ahead, Carrie Ann.
Yeah, I would also suggest, and I think it would be beneficial if, as a body, you sought to have a advocacy position on making a change in the policy of the age of access versus the age of consent, and how, because you're the service providers who are on the ground as midwives, right? As nurses, you're the ones engaging and working with our adolescent population on the front line. And so you are directly being impacted as well, because of the limitations of such laws. And so if we all come together and we pool our resources and our voices and we advocate for change, then we can start to get the traction that is needed to have the change happen at the policy level. And like I said, the same way how at BFPA, we've been able to create our own adolescent access policy that we use to support our position of not turning back any teenager or any adolescent who seeks services and assistance from us. It's a policy that can be used across the board. We just need to get the buy-in from all the relevant persons to see it as worthwhile and as important, and willing to stand on it and utilize it and come together as a united front. So advocacy is also really important, and being able to, highlight the challenges that we're having. Young people themselves have been talking about these issues for many years, many years. They complain and they say how it makes no sense, it's stupid. I can't understand how at 16 I can have sex, but I can't go to the doctor by myself, that kind of stuff. And
a constant battle.
It's the constant battle. And I saw in the chat, someone said something about raising the age. I'm assuming they're talking about the age of consent. I have to pull it up again. Honestly, I have to say that makes no sense.
I think that's it. Yeah.
I am sorry, but that makes no sense. That actually would do more harm than good. Aligning it really, to me, is more about bringing up the age of bringing the age of access in alignment with the age of consent. Because culturally for so long we've been able to consent to sex at such a young age. Raising that age is actually going to create greater problems, because you're talking about a behavior that is socially ingrained in us. And so we're going to have people then pardon me,
we will be filling the prisons.
Exactly. We're going to have people then simply just breaching the law.
Laws will be broken.
Being liable to being prosecuted for something that is culturally ingrained. Really and truly, we have to work on the other end of the spectrum. We have to balance providing the relevant comprehensive sexuality education to help young people to understand that just because you're 16 and you can have sex doesn't mean that you should, or that is the best thing for you, because of all the risks and the responsibilities
that we need to do. I think we need to really enforce that.
Coupled with still having the access to the services for the ones who may need, because not every young person who requires medical attention because of something sexual and reproductive health related, we're out there just having sex willy-nilly. We know many times it is abuse and assault that's happening that's leading to them even requiring our services. So it is a comprehensive approach that has to happen at multiple levels, but advocacy, coming together, advocating together, is going to be really critical for moving the needle forward.
Much appreciated, Ms. Hurley. One thing, we have Sharon Bishop. Sharon Bishop asks, at what age can a child legally give consent for contraceptives? And I'm sure Ms. Nichols would have addressed that in terms of the child's age of maturity. And so Ms. Sharon Bishop, I hope you got your answer. Yes, 16, you can have consent for sexual intercourse, but at least if your age and you're mature enough and you approach the healthcare centers with or without a parent, I believe that your case will be handled on its own merit. I think I speak to accurately on that. So far, from the information we have gleaned. Is it?
I had a question about the involvement of males.
Yes, I was not going to address that.
Yes, so for instance, the Bahamas and Barbados, do we address the males in these services that we are providing? Janelle?
Comprehensive, so it deals with all adolescents, male and female. So even for the fathers of pregnant teens, we try to get them involved in the care once the mother comes to clinic, because I mean, they're the father of this child. Now, an issue can come in based on, and I think, you know, when I was looking at the legal presentation, we have where anybody who's under the age of consent, if they come in, we now have to refer that to the police because it now becomes the police matter. So once that happens, then you may not see that male parent around, depending on the age of that person. So just like was said, if the child, if it's two 13-year-olds or two 14-year-olds, they deal with it accordingly, versus if it's a 13-year-old and a 25 or 30 or 40-year-old person. So it's right. So it's dealt with by the courts that way. But we have services there for all male adults. We have a male psychosocial counselor. So we have persons to be able to be there to address our males when they come in as well.
Yes, similarly for us, for our young mothers within the program, yes, primarily the core participants are the young mothers, but we also work with fathers. Part of our psychosocial support is extended to the fathers and other family members, because we appreciate that these young ladies don't exist in a vacuum, and they have an ecosystem that impacts them either positively or negatively. And we've found that honestly, working with the extended family members actually can either aid in them doing well within our programming, or it can hinder them. So that's both, whether we're working with the fathers of the children or their own parents or family members or siblings that are a part of their immediate circles. Within our comprehensive sexuality education program that is to all adolescents, no, both males and females, we also work with boys, yes, and males. We make sure that we address their concerns and their issues, and also we work with them together, because it's important for both genders to understand, you know, the different nuances of masculinity and femininity and how those things play against each other. So yes, our programs are also comprehensive in that regard.
Great, fantastic. That is lovely stuff. So we're not just, yes, we see the women, the young girls more, but we also address the guys once we have them and we capture them. One of the key things, one of the other, the as it relates to the legal age that persons that we are debating, it was noted that a lot more education needs to go on out there, and that is where I think we need to, as it was focused on us, we need to take the stance of an advocate and look at education, educating our young people as to what are the ramifications of their decisions at early ages, and how then they can use the law, how then they can make their best decisions. That is going to be a correct focus. I also see that Ms. Nichols have placed the the case she was referring to in the chat, as well as Gaelic and West Norfolk. So we need to look at those, and we really need to ascertain those, so that we can get that information and look to see where we are going from there. I had a wonderful time here with these questions, with these presentations, the information and the way we're looking at, and it gives us a framework to work with throughout the region. I see that we had the challenge, each presenter between Carrie Ann, Miss Hurley here in Barbados and also in Bahamas, having the challenge as it relates to the legislation, and the parental authority. Still that had that challenge as well. We also need to look at our education of our parents. As to the needs of our children, that is where we're going to also have to look at that. I also noted from Ms. Hurley's presentation where we had the HFLE being taught in schools only up to third form. So if they didn't pay much attention then, they will miss the information that they will need when they go on now, and where her program was then coming in. Now, this is something else again too that we may need to look at pushing for to get back on the curriculum for our school children, that we can have them with that education and that information right on hand, not just then when they go off into, some of them may never go off to college or even to university where they may access some of that information. So hence, where those latter 4 years or 3 years in school, where we may need from third form onward up to the fifth form or upper sixth or sixth form, they may need that information then so as to help guide them in making critical sexual health decisions in the future. So this is something that we may need to look at advocating for and having play on our school curriculum. What do y'all think about that? Any comments?
I think definitely that's something that needs to be done. We try to get into the schools now to be able to impart that knowledge. We also have a school health program in the Department of Public Health that also helps to educate the young people in our school system, and it goes straight up from the primary school straight up to grade 12. So I agree, education is key for parents and adolescents, for them to be able to understand the ramifications of having sex early, or getting involved in promiscuous behavior or things like that, and for parents to realize that yeah, they're children, but they do have a mind of their own, and they still should be treated with some respect, and they still need to be able to access the care that they need so that they can now become, adults who are healthy and happy and are able to contribute to society. So education on both sides of it needs to continue and to happen.
Yeah, and I can suggest if going through the schools is a challenge, if you're finding that you're having resistance getting into the school system, then try going through the community. You may have greater access through community organizations, through the church, just look for another way to get in. But you have to get in and provide that information, because as was just said, the education is the key. Education is the key. So if you can't get through one door, go through a window.
As one person puts it here, in addition to education, we need to support, we need the supporting environment and legislation in the addition to behavioral changes. I do thank you for that, Mary. It is very important. We need that. We need that. Education is key. And I'm looking here and I'm seeing many persons seeing that. And when we say education, yes, we need to educate our young people, but we also need to educate the parents on the need for education of the young ones, and even sometimes for the parents to get educated themselves. Because if you lack the education, you cannot impart it on your children. No, you cannot see that they get the information. So we may need to do education as a double whammy, both from the adult side and also from the children. And on a note, we may need to look at having a lot of peer counseling. When I say peer counseling, to get information across, we have some key young people, we have some strong young people whom we can educate and give information to, that they can also go and share with their peers. Hence, they will get some information coming across until we can get into the prime of life with them, where I'm saying where we are into the classroom with them, where we are into the social groups with them, and these and into every avenue that we can get the information out to them, to get them the education they need, that they can make the informed decisions that they need.
Yes, Marguerite, I'm so glad you said that, because that's actually the mode through which we do our education at the FBA. We actually have a team of young people within our youth arm. The youth arm is called the Youth Advocacy Movement, and there are peer educators that we train. So they're trained young people who are armed with the information, the accurate information that they need to go out into their schools and into their peer groups and be able to give back that information to other young people in ways that might be more palatable to them, that they may more readily accept, because it's coming from a peer who understands them and may better understand the nuances of what they're dealing with and going through. But the information doesn't change. The principles don't change. It might, the way it's put across might change, but it is still accurate information that is given. So we train them to do just that. And for the parents now, the adults, we utilize our social platform. So we have a radio show called the S Factor that we do, and we run it on one of our most popular secular radio stations, because that is where it has the biggest reach and impact. And we talk about a range of sexual and reproductive health and race issues on that show. And that show is a show where we educate a lot of adults about some of the same topics that we are talking to young people in schools and in communities about. We're also talking to adults about, but now it's in a different way, through a different mode. And they themselves now might be home on a Saturday morning, cleaning the house and listening to the radio and learning about, STIs and contraception and different things that they otherwise would not know about. So I just wanted to, but as you said that, it jogged my memory about these different ways that we can definitely get that information across and educate both the parents and the children at the same time, so they're all on the same page.
And with that, I thank you. I thank you, Carrie Ann. I thank you, all our presenters. I thank for all the information. And now I hand back, Dr. Curtis.
Marlo's hand was up.
Oh, sorry, I missed it.
So this one is for Ms. Pickering and as well as Ms. Hurley. Quite a few persons in the chat were very interested in how many of your programs were specifically geared towards the male gender. I heard you speak about the youth advocacy movement, but I would want to know if you have any specific programs set up for the male gender, so that they are leading in that arm of adolescent health and reproductive sexual health as well. So what programs, if any, do you have in your territories? And I'm speaking specifically to Ms. Pickering in Bahamas as well as Ms. Hurley. Could you please enlighten us?
Okay, so
they addressed it, but go ahead.
Right. So like we said, all of the programs that are in center are for both male and females. We also have male counselors who get the males involved in different types of activities. So going through different sessions with counseling and knowing how to deal with your emotions and anger as a male, being able to groom yourself. So those things are done through adolescent health with our male population. But every program that we have in our clinic is for both male and female. So we don't say that, okay, well, this is only, but except for the antenatal, of course, but even then we get the fathers involved. So all of it is geared towards both sectors as well.
And what role does the faith-based organization play respect to yours, Ms. Pickering?
We have NGOs as far as faith-based that come in and are able to provide that kind of support for our kids as well. We do provide, because our country is a Christian country, it's faith-based. But we have teenagers who don't believe in God. We have children who come in who are of they are involved in other types of relationships, so the LGBTQ community as well. So our center is geared towards ensuring that we don't put anybody out, that nobody feels that if they come there, that it is so holy that they are not allowed to come in, or they're going to be cast out because of this, that, you know, of their lifestyle or anything like that. For instance, let me give you an example. I had an antenatal patient who came in. She had ended up with an STI. So, you know, we treat their partners as well. So we asked their partners to come in. So she ended up coming back. She was there with a male. And then she came back and she brought her female partner as well. And her fear, she spoke to me, her fear was that we would not understand that we would say that, you know, it's immoral and it's this. And I told him that is not what we're here for. We're here to make sure that you are okay, that you get the treatment that you need. And I think too, with education, even as a healthcare provider, we need to make sure that we are in touch with what is happening in our adolescent population. So in touch with the lingo, in touch with, you know, what things they're going through, to be able to understand and to even go back to our own adolescence and remember the things that we went through. And that's what I tell some of my parents as well. It's like, you know, when you were this age, you felt this way or you did this way. So it's not strange now that your children are doing the same things. You know, as my Grammy said, nothing changes underneath the sun. They're trying to do the same things that we may have done. It's just that they have a lot more technology. They have a lot more access to information, not always good information, but they are exposed to so much more at such a younger age. So we have to be able to be in touch with what's happening in that population, to be able to provide the best care, the best referral if needed for this population.
And I think Ms. Pickering, that ties in nicely with Diana's question, because she's asking, how do you address a situation where a 15-year-old comes to the antenatal clinic pregnant and begs the midwife not to report, that she does not want her boyfriend to go to jail? She's asking that. How would you address a situation like that?
You know, that has happened on so many occasions.
Marlo, that would be the final question.
Yeah.
Okay. So it's happened on numerous occasions where they say they don't remember, or you know, teenagers talk. So they understand now that once they come in and they're of this certain age that they cannot say, they're like, oh, you know, I'm not sure, you know, who it is, or I've been with multiple people, so I can't give you a name. And that's what they do now. And the thing is that you can't force them, but developing that trust and that rapport with them, it eventually comes out. And like I tell them, I said, you know, it's by law that we have to report, or the physician reports it, and they may not know at some point, but we let them know. But a lot of times they don't speak. They don't speak because they've been educated by their peers as to, you know, if you're this age, then, you know, well, they say, well, I had sex at this age, which brings them to when they were 16. But of course, when you do your scan or when you do their physical exam, of course, you can backtrack now to when they got pregnant. So they're not hip to that part of it as yet. So you have to build that rapport. You have to talk to them. You have, again, education to let them know why. But honestly, if they do not give up the person, there's honestly nothing you really can do but give them the education to make sure that, you know, the behaviors that they were doing, that they, you know, we want them on a different road. We want them on a better road. We want them to be able to just make better decisions and be able to, you know, go on to be educated, be able to contribute to society, be able to raise that child well that they're going to have.
Thank you, Ms. Pickering. I'm going to cut now because in the interest of time, you know, it's going to generate so much interest and further topics, but I'm going to return back over to our very able moderator, Mrs. Peterson, so that she can wrap up so nicely for us. Thank you, Ms. Marguerite, and all the presenters. Awesome job done. So thank you. Over to you, Mrs. Cynthia Peterson.
Thank you, Marlo. Thank you, Margaret. I don't have the final say. We have Marcel, who is waiting to, you know, say say thank you to all the presenters, and you guys were very good and excellent, excellent, excellent all over. So now I invite Marcio to do the vote of thanks.
You're muted, Marcia.
Good night again, everyone. I just want to say thanks to everyone who took part in the program, in the webinar.
It's gone muted again.
You're still, okay.
For welcoming in us. Thanks to our president, Dr. Shirley Curtis, for welcoming us all to the forum. We want to say thanks for the remarks brought to us by Ms. Deborah Lewis on behalf of the UNFPA. Thank you, Debbie, and we know we can always depend on you to support CRMA. Also to our presenters, Ms. Janelle Pickering and her standalone adolescent services in the Bahamas. Thank you very much for that excellent presentation. As you realize, there was a lot of discussion surrounding the services offered in Bahamas. Thanks also to Ms. Kerry-Ann Hurley for the experiences and challenges of the adolescent services in Barbados. And we would recognize that there were a lot of similarities in the both presentations in the way that the services are delivered and to the clientele that they are delivered to. So we want to thank you both for those interesting presentations. We also want to thank Ms. Damanelli Nicholas and Ms. Alana Buchun for their presentation on the role of the Children's Authority in Trinidad and Tobago. Again, caused for a lot of generated a lot of discussion, and thanks for the information that you have given our members, our participants, so that they can go and look up the GILIC competencies, and also they could look at the Fraser case as well, that lent some credence to the GILIC competencies. So we know we have a lot of challenges in the Caribbean when it comes to our adolescents, because again, just the mere age difference and the differences in age of consent and the differences in the age of an adult. So we know there's a lot of work to be done, and we take your point that we can be advocates for change and maybe look at some policies for the wider Caribbean so that we can really help our adolescents. So I want to again thank all the presenters. We in CRMA are about sharing and networking. So we thank you for the various perspectives expressed here tonight. It generated a lot of discussion, and I think it's a springboard for us to look forward to other things that we can do for webinars for CRMA. I just want to remind persons to fill the evaluation form. The link is in the chat. The form would help us to plan future webinars. And also, if you fill the form, it would also generate your certificates so that you would get that once you complete the form. I want to thank all the persons who participate, our able moderator, Ms. Cynthia Pitter. Thank you very much for keeping us on track, keeping the time. Thanks a lot for moderating the session. I also want to thank our question and answer persons, Ms. Marguerite Bourne-Clark and Ms. Marlo St. Hill, for taking us through the question and answer segment. I know there's so much we can talk about. We can continue this discussion way into the night. However, time is against us. And so I would like to thank you all for being part of this webinar here tonight. And CRMA continues to educate, to network our members. And so look forward to the next webinar. You will get instructions on when that will be and the topic that it will be on. Thank you again, ladies. Thank you all for taking part.
Thank you.
Thank you, Marcia. And
Thank
you for thanking us. So I just want to play this for you. This is Kerry-Ann singing. So go on YouTube and download her music and listen to her music.
Awesome. So ladies and gentlemen, I think I saw a gentleman on, please.
He's there.
Yes, please get your evaluation. The Google form, it's there. Click on the link, fill out those couple questions, and you will get your certificate by the end of the month. Well, not by the end of this month, probably about in 2 weeks, 2 to 3 weeks, you'll have those. And I just want to make mention of the fact that tomorrow is the last session of the International Confederation of Midwives 32nd triennial. We're having an awesome time for those who are not registered, and that in 2023 we're going to Bali. So start saving your coins. maybe your dollars. Let's say save your dollars.
In US.
Start saving your dollars. We are going to Bali in 2023. And we look forward to greater participation. We're having a good time. CRMA is well represented in this virtual platform. We have presenters, we have facilitators. Yep, we're making our presence felt, but we even want a greater participation in 2023. So I'm going to put that out there. And in the short term, we have our AGM coming up in August. I don't have the date. It's the 3rd Thursday and Friday in August. Let me see what dates that is. So keep that in mind. So the AGM is free. So save those dates. I'm going to give it to you right now. 19th and 20th of August. That is going to be our AGM. So we look forward to seeing the same participation and greater at the AGM. So thank you very much. Have a good night.
Thank you.
And get your
Thank you, everyone. Good night.
Thank you.
Good night, everyone.
Thank you.
Bye.
Great presentations. Awesome.
Thank you. Thank you.
Yes. Carrie Ann, Ms. Janelle, and our legal
You're
minds.
welcome.
Yes, Nichols and Ms. Bukun. Awesome.
Good night, everyone.
Good night,
Have a
everyone.
good night.
Good night.
Good night, everyone.
Good night, everyone.
Good night.
Good night. Who was that, Keisha?
Yes, hi.
How are you?
I'm fine, thanks.
Awesome.
Good night, everyone. Very interesting presentations.
Thank you.
Thank you.
Shirley,
Hi,
have you
Sister
recorded?
Peter.
Good night, everyone.
Good night.
Have you recorded?
Good night.
Hi, good night.
Bonsoir.
Sanford is a modern Republican politician with his own history, right? It's Sanford, you will recall, was serving as governor of South Carolina.
She don't put me to leave.
And his office.
Hi, Hazel.
Sudden, not pre-announced trip to go hiking.
Hi, Shirley.
How are you?
Not too bad, not too bad. Marcia, give me a call tomorrow, please.
All right.
Okay.
Bizarre scandal following him every last day.
Sounds good.
Yeah. The next time, probably when all the presenters are in the chat, we could take a screenshot before the persons coming. Yeah.
Yeah. Yeah. That would have been a good idea. Awesome. Even though we had 400 and something persons registered, I think we went up to like 280 something. I think
Yeah.
about 280 was what I saw. I think, I don't know if we send it out too early, but I think the weekend you give people time to plan, but they register and then they forget.
And there are many presentations in between, because today while at work there was one going on with NAJ. So you know, although I have the phone and I wasn't really listening. So,
right.
You know, so there are many, you know, many things going on one time.
Right. Yeah. Okay, did everybody get the link?
Oh, get the form
Yeah.
for registration. No registration.
I'll put it in last time.
Oh, yes. Google form to full. Okay. You save on the Google Drive. No. I gonna look at the email.
Marlo, you just ready to wind up, you know. You were just getting to us, ready to ask a question.
I was making sure that there was no other questions left unanswered. Just making sure that you answered. It was a good talk.
I'm Madam Marguerite. I mean, she was on a roll. I say she could ask the question and answer it herself.
Next time she's going to be the presenter. She's going to be the next presenter.
She was so passionate about the thing. I say.
She asked a question and answered it before.
Yeah, man.
Seek confirmation.
That's the energy we get from the girls once we get into this thing, you know. We gotta push the energy because we can do this as a regional body. This is not beyond us.
We have to change behavior because most of us here are parents, and we are parents, we are midwives. What is it that we are doing? Do we have the same views like other parents?
Right.
Would I want my daughter to be getting seeking sexual and reproductive care behind my back?
Without, yeah.
So you see, you have to look at it as a mother as well as a
healthcare provider,
as a healthcare worker, because you have to straddle that.
And you also need to view it from a child's perspective. You give them consent at 16 years old. Permission to consent.
Once you give them that 16-year-old consent, then I think it's incumbent upon the healthcare worker to at least approach the parent.
I believe if we address parenting, a lot of our young people are neglected. They are neglected, and that is why they end up into doing risky behavior because there is no parent.
It starts from the home. It starts from the home.
Get the fathers back inside the home to let the girls feel of self-esteem.
Yes.
A lot of times they go, it's not sex they want to have, it's the love they're seeking.
Yes.
That. But I didn't want to
Dr. Curtis, have you stopped the recording as yet?
Well, child, yeah, I think, Marcia, you stopped the recording, yes, no?
I'm seeing that it's still recording, so this is good fun.